you guys are doing that, I will say hello to everybody and welcome. I'm Tracy Gary, and I used to be a former Detroit broadcaster in Phoenix also. That's the feedback I was warning you about coming off of Facebook. And so I got sick from breast implants. I had breast implants for 20 years. I had 2 sets of them. I got deathly ill, didn't know what was going on. I was never warned by any doctors. No doctors figured it out. The internet figured it out. These women here with me, they're the ones who helped me figure this out. We all figured it out together with the help of social media. And so now we're pushing for legislation to try to get women more aware. So we're going to talk about that. With us is Dr. Khan of Executive Plastic Surgery, and that's in Novi, Michigan. And you're a board certified plastic surgeon. We're going to discuss any questions anybody has. So we're going to be watching several of these where we're pushing this onto any of the pages, and we're going to see if we can answer some of your questions with Dr. Khan. He's done numerous explant surgeries in Novi, and he can explain what an enbloc is, proper enbloc is to you. And we have Dawn who's with us, and Dawn has a couple of questions for Dr. Khan as well. And about capsule, we all have questions about capsules, and Dawn's a breast cancer survivor, and when she removed her breast implants, she went to a flat closure where I got a lift, so she went to a flat closure, which is becoming quite popular, and I don't have any complaints from any woman who has done that. They all seem to be quite happy. And she's also a patient consultant, and she is part of the Michigan legislation team. And then we have Becky. Hi, Becky, down there with the gorgeous hair. Becky said she was bald. I didn't know you were bald for a while. So yeah, she's also a breast cancer survivor. And she also explanted and had a flat closure. So I think we want to talk to you about flat closures, Dr. Khan. And somebody's getting feedback from their Facebook feed, I think. And then Becky also made a documentary, which I really loved your documentary. I loved it. It's on YouTube, right? Is where I saw that. And it's called Explant to Flat. And it was really well done. Bravo. So it's a great documentary to go watch. So thank you everybody for joining me and discussing all of this, because we want to try to not have women stay sick or, become sick. We want to try to prevent it out of the gate. So if we can't stop them from putting implants in, but we can at least warn people. So we'll start with Dr. Khan. Welcome, Dr. Khan.
Thank you very much, Tracy. It's a pleasure and honor to be here again with what I would say the leaders in BII, the ladies that are making a difference every second of the day, with the many thousands and I would say hundreds of thousands of ladies that you have reached over the years, and that you will continue to reach not only in the United States, but also North America and Europe, South America, the Middle East, and literally how breast implant illness is affecting the many and the masses. And so again, many thanks to you for arranging this. I'm more than happy to discuss. I just wanted to say, I had a very busy schedule. Today I removed the largest breast implants I've ever removed in my career. These were the 1200 cc saline implants. 1200. Again, this is a lady from Arizona. She comes in, she had 800 cc implants that were basically filled with saline to 400 extra. So 800 plus 400, 1200 cc's each. Wow. And so that basically took me till almost 4 o'clock. I did a Facebook Live right from the operating room, and then I had a FedEx patient of mine. She had a bad face trauma, so I took care of her. I meant to be home, shaven, and basically presentable, but I decided to stay here. We had some snow yesterday, so I did not want to be late. So
you look
and
more
thank you
authentic.
again. Oh, no, thank you very much. Tracy, you and I go back till 2018. I remember I called you up and basically I said, Tracy, I'm doing a live, basically Facebook Live, my first one ever in my career, and it was at the hospital here in Novi, the big hospital, and you came with your husband, and I had all my patients, and this was the summer of 2018, where I basically came out and I said, you know what, this is my legacy. This is going to be what I'm going to talk about. This is my experience with breast implant illness. And I remember a few days ago, you and I had a lengthy discussion because you're like, who are you? And you're right in my backyard. And I know BII, and I want to screen you. I want to filter you. I want to test you. I don't believe you're right here. And I had to go all the way to Costa Rica. And I remember you and I talked multiple times. You were here physically with the other Facebook Live and the other documentary we did with the group from Los Angeles that came in. So you were here as one of the guests. And again, you continue to be this big voice in the world of BI, along with Dawn and Becky Richard, who have truly, truly, this is what it takes. More of these healthy, nice discussions that will change the world for the better.
I agree. Well, thank you for all of that. So what year did you start? Your very first explant surgery was what year?
So I will say, looking back at my career, so I started off, so kind of a big overview. I'm a board certified general surgeon. So I've done a lot of mastectomies and lumpectomies, radiation, whatnot else as a board certified general surgeon. A big part of it is breast surgery. Then I did my so I'm board certified in general surgery. And then I did plastic surgery. And as a plastic surgeon, again, a good gist of plastic surgery, well over half is what is breast surgery. And so I saw firsthand in my career from my training as a general surgeon and also training as a plastic surgeon, the detrimental effects of what are breast implants. And again, when I started off in Yale, when I was a resident there, a surgical resident categorical, in the year 2003, I saw.
Did you say Yale?
Yeah, Yale. So Yale New Haven Hospital, the main hospital, which is basically the reputable organization that sets the standards not only for the US, but the rest of the world. So when I was there, I saw firsthand, and remember at that time, the silicone implants were banned. And so I saw, and I basically took care of patients that were coming, and I saw the side effects of basically the implants, all those ruptured implants, the really hard calcified. So very soon I established what was an experience. And then when I did plastics, we had exposure to the reps because we all have contracts and accounts with the big manufacturers, especially Allergan, Mentor, so that when we do decide to order implants, Botox, whatever it may be, we basically set up these accounts so that we can get them if we decide to go into private practice, which is what I did, and so that we have an established account. So I said, I'm not going to do that with any of these manufacturers because this is not my cup of tea. If anything, I'm going to do everything else, this being the most common procedure that plastic surgeons do. So I said, I am not going to get myself involved. And my friends were like, how come? Because everyone does this. This is basically the bread and butter of what is a true budding new plastic surgeon, because this is essentially what plastic surgeons do. The number one most common surgical procedure done by plastic surgeons when I started was augmentation. So now as I move and I'm doing face trauma, face cancer, skin cancer, hand, for example, leg reconstruction, I said I am not going to augment no matter what, which is a very straightforward operation. Remember, there are a lot of non-board certified plastic surgeons who are doing it, dermatologists, OBGYN, emergency room docs right here in Michigan, believe it or not. And as we know elsewhere in the US, and I told myself I was not going to do something that I felt uncomfortable doing for what would definitely be very financially rewarding. Now, as I saw a patient that I did hand on, for example, I said, you know what? She said, can you replace my implants? I said, no, I'm not. I'm just going to take them out. So I started. Now, remember, all of us as board certified plastic surgeons, which is basically the American Society of Plastic Surgery certification, we never got trained in what is enbloc. How many of these did we do in our career? No. So this was something where I myself kind of, as we move forward, sending the capsules off, looking at the lymphoma rates, which is essentially minimal to non-existent, I said to myself, I'm only going to explant because this is what I believe in. Now, this one case that I did was a young lady in her 30s. She had a breast cancer, and I did reconstruct her, which was a nipple-sparing mastectomy. And she basically was the one and only patient that I did in order to get board certified, because they want to make sure that you have breast case, face, head and neck, trauma, kids, hand case, for example. So as I moved along, I saw what I knew all along, what was explant surgery and how it was very early on, and not many people had even heard of the term BII. So this is going back to 2014, right? It was essentially very much in its infancy, and the implants had just been introduced back in the market, the silicone implants in 2007. Now going back to this, so I did one here, one there, and essentially in 2015 a few. And then as I moved forward, I realized now all my mentors, my professors, the textbooks, even to this day say you don't have to remove the capsule, they are safe, the body will absorb them, and the body basically the risk of removing the capsule is certainly too high, so that leaving the capsule behind is very much acceptable and very much the norm. And that, unfortunately, that thought process still continues to this day. So going back to now, when you and I first met in 2018, when I did that evening lecture, where unfortunately not a single physician, breast surgeon, or a plastic surgeon attended, this is where I felt comfortable that, you know what, I'm going to go ahead and speak. I'm going to get the questions from the audience, and I'm going to put my reputation on the line, and I'm going to discuss what I strongly believe, what is explant surgery and how it needs to be done. And this is where you and I talked at great length, and where basically you felt comfortable about how, and that's why you even showed up, because you did not want to back me up and if I was not who you thought I was going to be, right? So going back to, and again, this is back in 2018. Now, it was a big deal for me because my friends, even to this day, say, why do you do these lives from the OR? One day it will come back and haunt you. This is a lot of critical information, where this is a topic, if you group together 100 plastic surgeons, all 100 of them will likely negate what is breast implant illness. And here I am, look, today I did a Facebook Live. I'm removing the implant capsule, and I strongly believe in it so much that in 2018 I came forward. So I needed to have known all of that, and I knew that in 2015, 16. But as I moved forward, I saw the pathology. I saw my patients that I did over the years from the 1998, ever since I've been in the operating room. So I knew very clearly early on, explant surgery essentially boils down to the fact, and this is the lecture that I gave in 2018, removal of the entire implant capsule and all inflamed tissue such that no burden remains behind. And that ever since that day, essentially the gist of my practice has been explant surgery and nothing but that. So almost 95% of my practice currently is explant surgery. And this is, I do 3 maybe on Tuesday, 2 on Wednesday, 3 on Thursday, maybe 2 on Monday. As you know, I have access to the operating room. I can go whenever I want. I've done even on Saturday. And I do them at the hospital for those high risk patients. So hopefully that sheds light to my experience. Now I will tell you, I mean relatively young. I don't have that much gray hair, but I would say this: I am so honored, intrigued, humbled, and I feel so positively energized that in my young career, right before my eyes, what I believed in and I let go is truly being translated into what hopefully will establish itself to be the standard of care, where the entire implant capsule and all inflamed tissue must be removed. No capsule must be remained behind. All capsule must be sent to pathology. Cultures must be taken. Implants must be returned. There needs to be complete transparency of the video of the chest wall showing complete removal of the capsule. There's checks and balances from the patient. Implants returned to the patient, and that all capsule must be sent to pathology because that's the proof that there is no lymphoma, and that all fluid must be sent to cytology to rule out BIALCL, which is a CD30 analysis. And so this is, in a nutshell, my emergence, my establishment, my thought process for someone who has every right as a board certified plastic surgeon, to augment tomorrow. Today I could have done 6, 7, 8 cases. My friends do 8 in a day. 45 minutes to an hour, 15 minutes, and they are fast, saline or silicone. I would be making 3 times as much with a lot less drama, if you will. But right now, for me, I am humbled to say that whatever I believe in is truly translating right now. Look at the FDA, October 27, 2021, a few months ago, 4 months ago. They put forth this mandatory warning, which Dawn was working on along with Becky, Richard, and you and the rest of the group, in regards to the mandate that all plastic surgeons have to discuss seriously with basically, signature feedback that they were told, informed consent in regards to the detrimental effects of what are breast implants.
Well, Dr. Khan, I have to add too, that if it weren't for surgeons like you that take the time to do a proper explant, we wouldn't have a voice. We would still be sick. So it's so great to just know that there are surgeons on our side. It's huge for women who are very ill, because a lot of surgeons are telling women that breast implant illness does not exist.
Now, I will tell you that is absolutely 100% false. The implants, as we know, the FDA warning clearly, they're slowly inching towards what is a ban, hopefully will occur soon. The implants are not meant to be in the body forever. Number 2, they are associated, especially the textured ones, and certainly the smooth ones too, with what is BIAL-CL. And the third thing that the FDA put forth was BIA is very much real. And if you have these symptoms, you need to seek care by a board certified plastic surgeon so you can get these things, these issues addressed definitively. And so it is very much real. Absolutely, absolutely 100% real. And we look at the ladies in the masses, what Tracy said, look at all those ladies that have explanted, how happy they are. They're back to their life again when the explant is done right.
I have a question, Dr. Khan.
Yes,
a lot of women that come to me that have had breast cancer ended up having implants that were placed under the muscle. And one of their big concerns is that, I want all that capsule off, but I don't want a pneumothorax. I can tell you, I had a bad situation before I started, and I'm very small framed. And my doctor, I told her, I don't care what it takes. I want all that capsule off. I'm too sick. I feel like I'm dying. And she said, you're so small framed and there's so little room there, you may very well end up with a pneumothorax. And I did have one.
What is
very
that?
small one. And I will tell you, I had my wound back on. I recovered in such a quick amount of time. They thought I was going to have a home nurse, and I had her for a day, and she said, you're all healed up. My question is, these women, is the risk factor really worse to get a pneumothorax than it is to leave that capsule in there? To me, that risk factor wasn't enough to turn me away from getting all that capsule out of there and getting a proper explant with enbloc.
And when you answer it, can you tell everyone what that pneumothorax is? Did I say it right?
Yes, pneumothorax.
Yeah.
Can you explain what that is too?
Yes. So
for people like me.
Yeah, no. This is again, so pneumo means air, right? Thorax is basically in the thoracic cavity under the lung. Now, basically, as you will see, the implant majority of the times is placed underneath the pectoralis muscle, directly on top of the rib. Now, if there is penetration, violation of that intercostal, i.e. the muscle in between the ribs, such that now there is an air that leaks into the thoracic cavity, the pneumothorax, then it becomes a surgical emergency, because what happens is the lung collapses. So now a chest tube needs to be then inserted into the lung. Now, I will tell you, as a board certified general surgeon, I have placed countless hundreds of chest tubes in the trauma bay. Someone comes in with muffled heart sounds, meaning decreased breath sounds or shortness of breath, difficulty breathing. Someone on the road, on the highway, is basically in a car accident. What is the first thing that the paramedics do? EMTs, they put a needle right in the chest, let the air out so the lung can re-expand. Something that is a very straightforward operation. And I will say this to you, I feel more comfortable putting in a chest tube than sending a fax on a fax machine. Without any exaggeration. That is how simple it is. If you ask an emergency room doc, they will tell you they do this so often. It is a very basic, simple procedure, which can be life-saving. Now, remember, you have another lung. You just have some difficulty breathing. Now, the question becomes, what is more important? To not get a pneumothorax, which is, again, is a quick fix. You put a chest tube in, you basically put it to wall suction and essentially pull the air out. And then this is usually a small pneumothorax, which is air. And then you put it to water seal. Now, nowadays you have small chest tubes that you can basically seal off. And then once the lung re-expands, you just remove the tube, and maybe in a day, 12 hours, the hospital stay is a day or two. The patient is usually discharged. They get serial x-rays. And essentially that's the end of that. So very straightforward. Now, which is worse, to get a pneumothorax? Now, I will tell you, yes, in some cases, a pneumothorax absolutely can happen, but the risk of leaving the burden behind and continued misery of BII, and to basically say, you know what, in all patients. Now, this is where I said to myself, I'm going to come up with rules. So this is where I came up with 100-100-0 rule, which is 100% of the time, 100% of the capsule must be removed, with 0% of the capsule remaining behind, regardless of the patient's BMI status. If you're as thin can get, or high BMI. If you have a blood thinner that you're taking, if you remember, Tracy, Gary, you were here last time, this one lady, she was on a blood thinner. Guess what? I bridged her with Lovenox. I did her surgery, and she was very appropriately given the same surgery that all my patients get. Another patient was on Humira. She sought consultation for another surgeon in Florida, and she was told, well, you're high risk. The risk of wound breakdown is there. So you are not going to get complete removal of the capsule for your own good. Wrong. She should get the same surgery that my 81-year-old patient got, my 22-year-old patient got, the patient with juvenile rheumatoid arthritis who has been living with rheumatoid arthritis for 40 years. Now, you can optimize the patient. You can discuss with the patient. A patient who's got radiation will get the same surgery. The goal here is to not leave the capsule behind, because you don't want that patient to continue to suffer from the BII symptoms. And the risk, so essentially, the risk of a pneumothorax is so minimal that it cannot justify leaving the capsule behind, period. Now, I will tell you this, if a plastic surgeon feels uncomfortable operating on the rib, and they feel uncomfortable putting in a chest tube, then they will not take the challenge of removing the whole capsule, simply because they don't want to be in the proximity of the rib cage where the potential for a pneumothorax is there. Because if it does happen, the only other option for them would be to call 911 in the middle of their surgery and not be able to put in a chest tube. And that is the ultimate confidence of training, if you will. If I did not know how to put in a chest tube, I would feel absolutely uncomfortable doing the dissection off of the rib. Sorry, these light sensors are on.
They must be motion sensor.
Yeah, motion sensor. Just 1 second.
He's got a Harry Potter move coming.
Gotta move around a little bit.
Oh, that was good timing on my
Yeah.
part.
And just FYI, I don't see it live in my feed, but maybe it's floating around somewhere.
Okay.
So as you were, Dr. Khan, with a pneumothorax, so the pneumothorax shouldn't deter anybody from going through and getting a proper enbloc explant.
Correct, absolutely.
Thank you.
Because it is not, it is, which is worse, a pneumothorax, which is just taken care of transiently, or leaving behind the capsule where the patient continues to suffer from the BII symptoms, and the patient continues to be hurt on a daily basis because of incomplete removal of, look, I put forth the pathology report yesterday on my Facebook page, and it says silica, basically histiocytic reaction to silica. You don't want to leave that behind, because now the body will continue to mount that immune response and continue to cause those triggers of what is breast implant illness. And again, for the listeners, what is breast implant illness? Breast implant illness is the body's immunological response to what is the silicone within both the silicone implant or the saline implant, the outer shell of which is silicone, and the body continues to fight and recognizes that it's foreign. You see this in the many pathology reports with the giant cell reaction, histiocytic reaction. You see the chronic inflammation. You see the reaction to silica. And that is classically the pathologist clearly showing what is the body's uh, immune response to what is fighting something foreign. And hence the many symptoms of BII, as we know, the constellation sign symptoms of the most common being malaise, weakness, fatigue, migraines, vision problems, dryness of the eyes, throat clearing, neck, back pain, headaches. You have psychological issues, suicidal ideations, anxiety, panic attacks, neck, back pain, shortness of breath, palpitations. Look, one patient that came today, 41, this is the one with the 1200 cc implant. Her major complaint was palpitations. She just feels the heartbeat so fast and is a very eerie feeling like her heart's going to jump out of her chest. GI issues, endocrine issues, autoimmune issues, connective tissue disorders like fibromyalgia symptoms, arthritic problems, tingling numbness in the arms, legs, Raynaud's phenomenon, vasculitis, blood pressure, strokes, believe it or not, as a result, and many, many other symptoms from vertigo, tinnitus, name it. And the list goes on, and literally every organ system of the body is affected.
I think Becky had a question about symptoms, and I think you were wondering like what was the most unusual symptoms or something. Maybe you could phrase it better, Becky.
Yeah, well, you mentioned a lot of the common symptoms, Dr. Khan. But I was wondering, can you tell us of some symptoms that maybe are not so common? I know a friend of ours who's working on the legislation with us, she's had neurological symptoms, and she was actually told she had MS before her explant. So,
Right.
and she was walking with a walker. She was so sick. So I'm just wondering, what are some of those symptoms that maybe aren't so common that you see?
So very common, as you will see, the Lyme disease, it mimics Lyme disease. So number two, lupus-like symptoms, positive ANAs at sometimes and negative ANAs, which throws the rheumatologist. If you look at one of my patients I took care of like 3 weeks ago, she had seen 7 rheumatologists, and one was negating the other, and one was saying, well, we don't have much to lose because you're not feeling better, so let's throw in some strong medications, the immunomodulators. So Lyme disease, MS, again, the way it quote works with the nervous system, where patients complain of tingling numbness in the arms and legs, they get an EMG, which is nerve conduction study in the neck and the nerves of the peripheral nerves, and all these studies are unremarkable. And basically they're told we do not know, or you have psychological problems. So the unusual, atypical, the MS, I would say, is atypical. As we know, there was a report actually out of England where a patient was told she has MS, and after the explant, her symptoms cleared. The one patient.
Just a side note, that woman that explanted who was told she had MS and was walking with a walker, she just did a 5K.
Wow. See, this is impressive. Yeah, this is impressive. And see, this is where her story needs to be told. This is what we need to share, because you know what? It is these type of discussions, healthy discussions, we need to get to. If we look at the many articles, the rheumatologists publish a lot on breast implants, right? If you look at the allergy immunologists, they're basically publishing a lot. Endocrine doctors are also or the endocrine doctors are also publishing a lot. But remember, this is the primary care physician who's seeing this. Now, going back to your question, Becky, now this one patient today that came in, she was on 3 medications for hair loss. Now, when I talk to 100 women, maybe 3 to 5 of them will say the hair loss is kind of there. Maybe it's old age, or I used a different shampoo. But believe it or not, hair loss is one of those atypical ones. Another one where I saw a patient came, she was just sweating profusely. Like literally she would walk a block or two and the whole face would drench in sweat. Now she had seen a thoracic surgeon for like basically the sympathetic nervous system, i.e. cascade. She had seen a neurologist. She had full workup MRI. Essentially, she was basically confined to her home simply because the amount of sweat. Now, very unusual. I have not heard it. And I tell all my patients, listen, there is no lab test. Now, if we look at all the lab tests that exist, comprehensive, basically metabolic panel, which includes LFTs and all the chemistries. You have complete blood cell count with diff, ANA. You have the rheumatoid factor, and all these other rheumatological the markers, CRP, ESR. Now, if you think, and the thyroid function tests, for example. Now, if you think about it, I just mentioned 80% of all the labs that a person can have in order to basically kind of do the workup, including coags, just to kind of be complete. Now, you can also get other markers that look at specific rheumatological issues like ssDNA, which is suggestive of lupus, among many others. If you think about it, the lab workup has been done and the ladies keep repeating the same set of labs where all the labs come back negative. So the labs don't show or conclusively prove anything, but it's important to at least rule that out. Now, imaging, mammogram, ultrasound, MRI. These are the three. After this, and again, there is no diagnosis of what is BII. So it's a diagnosis of exclusion for someone who is in their 40s, for example. This is my second patient. She has all these symptoms, 25, 28, 30, 40, sometimes 50 symptoms of someone young and healthy. And if you double their age, they're still younger than the president of the US at present, right? And they have a whole life ahead of them, what it would be. And we can say with certainty, look at the other patient who had similar symptoms. And when she explanted right, you can see she bounced back. And hence, it has to be BI till proven otherwise. So some patients come to me and they say, well, 110% is BI because that's exactly what my friend had, and she had resolution of her symptoms when the surgery was done right.
So can we back up a little with going to the capsule on the ribs and stuff? Because I thought Dawn Ann had messaged that you were using a tool. Is that right? That you saw, or you thought you saw him using a tool?
Yeah,
and
I was wondering if that was a
about that.
cauterization tool that I was watching a live, I think, gosh, was it yesterday or the day before? But you were removing the capsule from the rib area and
Right.
it looked like it was evacuating as it went. Was that a cauterization tool?
Yes, yes. So the Bovi cautery is the standard and the ideal the tool that must and is only utilized for dissection of the capsule off of the rib. So this is used during colon resection, for example. This is used during gallbladder. This is used by all surgeons pretty much exclusively all the time. We just don't use the surgical scalpel. So this is where you actually cauterize, burn the small blood vessels, the capillaries, in that avascular plane. Now, according to the standard, now, if you went and looked at the Bovi cautery 20 years ago, everyone was smelling the fumes from the connective tissue that was burned. So now there is a standard of care where there has to be a smoke evacuator. And that's what you see, that tubing that connects right next to the tip. So as I burn, the machine turns on and automatically sucks all that smoke so that I don't inhale it. And
Nice.
I have healthy lungs. And they say that is so strong, it's like you're smoking a cigarette times 5. You know, that's how intense it is. So for that reason, that Bovi cautery is that tool that's used to dissect. As you can see, it leaves essentially no blood, and the care sophistication, just like a paintbrush directly off of the rib. I know exactly what video you're talking about, and this was a video to show that you can do the surgery safely without the use of drains and with minimal blood loss. But you don't want to be zipping through that with the Bovi cautery because it inevitably will lead to no finesse and blood loss, and basically that will mandate basically putting in a drain. You don't want to leave any of the capsule behind because you have to delicately raise it off. Look at the 1200 cc implant that I removed. It took forever. I'll tell you, I was tired, and I'll tell you, I'm still tired, but I, believe it or not, from the first day I talked to this nice lady, may God bless her soul. She was so nice that she let us share her video, and again, I think this is the largest single implant that man can put into someone's body. And I don't think, and I'll say this boldly, I don't think there will ever come a time where I will remove more than 1200 cc implant in my life, in my career, because no one's going to be quote that crazy, lack of a better word, or unprofessional to put in 400 cc's on top of what is an 800 cc implant. Now the care, the sophistication, the dissection has to be done pristinely, so the blood loss is minimal, less trauma to the tissues, less weeping of the tissues, essentially zero chance of leaving the capsule behind because you're taking that care, that meticulous effort, and the overall leads to a better aesthetic result because you're not going into the breast tissue, you're not cutting into the muscle, so you preserve all the aesthetics.
Yeah.
So to answer your question, there's a suction for the smoke that goes directly into the smoke evacuator, and there's no smoke, nothing. If you go to the other, so at any reputable operating room in the US, now you have to have a smoke evacuator. 10 years ago, if you were to walk in the OR, you would smell from all these 20, 30 ORs, all the smoke like it was the 4th of July.
I couldn't imagine it because I did dentistry for over 20 years, and we did a lot of cauterization with our implant dentistry, and we did not have a little vacuum besides the suction for dentistry. So I can totally relate to that. I'm glad that you have a great suction system.
Yes, yes, yes. No.
Dr. Khan, we have a question from the live feed.
Yes, please.
Someone is asking, do saline implants leach into the body? Maybe you could address the shells of the saline implants and how they compare to silicone implants.
Got it. Now I will tell you, the analogy I'll make here is a good question. So saline implants are as bad as silicone implants, period. Quote me on this. We know anecdotally, and I know, having taken care of so many patients with saline implants, that they have the same suicidal ideation, the joint pain, the headache, the migraines, the same set of problems. Look at the lady today with the 1200 palpitations, same set of problems. Now, someone might say, well, it's saline. Guess what? 95% of it is saline, but the shell, if you will, is silicone. And we know that gel bleed is occurring. Now, how do we know this? If you go back and look 2 months ago, 3 months ago, I took 550 cc saline implant that was intact from a generous patient, and I sent that implant to the Netherlands, to Dr. Henry Dijkman. He took the saline out of that saline implant, which is supposed to be just sodium chloride. That's it, right? This is what we give to a newborn or the 80-year-old who shows up in the emergency room and they give a liter or two, right?
Mm-hmm.
So Dr. Henry Dijkman took that saline from that saline implant, centrifuged it at 11,000 RPM for almost an hour, collected a sediment at the bottom and looked at it under electron microscopy, only to show clearly that there were silicon particles within the saline of the saline implant.
Wow.
I showed that on my Facebook. I basically, so for those patients who are curious, this is electron microscopy. This is like me, I'm looking at Tracy, I'm talking to Becky right now and Dawn. This is as real because we have standard protocols. And if you go back, look at that Facebook Live I did with Dr. Henry Dijkman, there are clear controls that show this is the same silica particles that's seen in the lymph node tissue that is seen inside the saline because there are established controls. And Dr. Henry Dijkman has shown clearly there is gel bleed occurring, and I see it. So if you look at, I'm going to go ahead and post another video. This reminds me that I took a couple of weeks ago of a patient that had textured implants that you can see once I wipe directly on top, there is this slime that I see. Now, implant is intact, but when I go like this, the same gum sign, like a ruptured implant, you can see that stickiness. Clearly, this is the gel bleed. And so clearly, saline implants are as bad as silicone, if anything worse, because they give you the illusion they're safe. And they cause the same detrimental effects what silicone implants cause, period. They need to be recalled as much as the silicone. And there is conclusive evidence, as I just showed you, there is no negating the fat. We need to have more of these studies done with electron microscopy and energy dispersive x-rays that show saline implants are not safe. And you can see the outer wall of the saline implant, which is the silicone, how it's breaking down. And this is what Dr. Henry Dyckman showed.
Thank you.
Welcome.
Wow. I don't think any of them are safe, but the silicone, when that gets loose in somebody's body, it's almost like, I don't know how they could have put those back on the market, the silicone. I think they should all be banned, but they're not, that's another argument.
Yeah,
But
yeah.
the
No, this is-
silicone getting loose in your body, like you can't get it out. But yeah, you're saying now we're all at risk for it.
Right. And now the other thing here is just like saying I have a cigarette that has a nice big filter on it. It's safe. It's good for you. No, it just that can cause cancer as much as the heavy cigarette without the filter, or the cigar or hookah or whatever it may be, because they're all bad. And now what you just mentioned is like another very interesting topic, Tracy. Juul cigarettes, right? They're not safe for any of us. Guess what? The 17-year-old kid with the 7-year-old lungs, he's still puffing away. Unfortunately, going back to Becky, what you were saying, and Dawn and Tracy, what is the goal? Why am I doing this? Like, am I having fun kind of swimming against the stream? Trust me, I would, I would love to be invited to the many other plastic surgeons parties this past Christmas, right? The bottom line here is, for me, I took an oath and I said, do no harm. Implants harm.
God
Look at
bless you.
the only harm. No one walks into my clinic and says implants are making me healthier. They're making me energetic. They're meant to be forever. It gives me a boost. No, the implants, on average, the FDA says 10 to 15 years. From my experience, 7 to 10. I have a lady that's coming. She had implants just a year and a half ago. She wants them removed. Implants cause pain, the contracture, infection. They basically, ladies are afraid to get mammograms because they don't want undue pressure, on their saline or even the silicone that might cause rupture. They have, remember, they're basically, if put and when put below the muscle, compromise the pectoralis, and the patient cannot use her upper arms the way she would, or like a bodybuilder would, if when the implants are placed above the muscle, for example. And you have the risk of lymphoma. You have the all the symptoms of BI. Implants are only bad. They are not worth it. And this is the safe take-home message for a young lady who wants to put implants and the risk of silent rupture. Look, there's a patient that came in 3 years into what our gummy bear implant placement live from the operating room. 3 years later, this young lady in her 20s had a ruptured implant on the left implant, right? So she was, God forbid, living. There was another patient with the white paint. It was all bacterial infection, right, that she had.
Oh.
We don't want to be hurting our bodies. We need to basically practice safe, healthy medicine. Implants are only bad. They are not good, and they're not worth it, period.
Yeah, we have another woman on our legislative team. She had breast cancer the same time I did, and but she didn't get chemotherapy because my BII symptoms mirrored my chemotherapy symptoms. But she didn't have chemotherapy, and hers made her horribly sick right away. She only had her implants in for 4 months. And she said, get these things out of me. They're making me sick.
Mm-hmm.
So yeah, they can affect people immediately. Some people.
Dr.
Right,
Khan,
Definitely need to change the narrative, whether it's, people going for augmentation or reconstruction, kind of change the order that things are presented as options, because we really need to put the patient's health first.
Right,
Yes.
right.
And
No, I will
everything
tell
else,
you.
and they know the consequences that could come, or the symptoms that might occur, the sickness or the cancer, and they know that, then that's another ball game. But we just really need to change the narrative and
Right.
push healthy.
Unfortunately, I will say this: if someone gets breast cancer, they go to the breast center, and there's the plastic surgeon. They get channeled through next plastic surgeon. Like, it's like you don't have much of a choice. It's like, oh, this is your right. This is your basically feeling that you're going to feel like you're going to be back to normal, type of a, now the problem here is there needs to be informed consent. And this is what you basically are working on along with the rest of the team here. If I told you, Dawn, Becky, and Tracy, and everyone else who's listening, all right, we live in the Motor City, so we can talk cars. I'm going to sell you a car that is only going to last you 10, 15 years. I say 7 to 10. It might blow up on you, i.e. get cancer, and it might give you transmission, axle, electrical problems, radiator problems, misfiring. Would you consider buying that car? You wouldn't even look at it. You would run away as fast as you would. Now, the same thing, if I told you implants cause this problem, 10 to 15-year lifespan, right, in the body. Number two, risk of lymphoma. And number three, the BI symptoms that we talked about and all these other symptoms, would you even consider it? No.
No. But
And
many women are being told these are lifetime devices.
Yep.
Yeah. And this
So
is the mandate. Yeah, this is what you are very generously and very importantly working on, just to let the world know. These are not, they've decided they're not meant to be in the body forever. And this is the healthy discussion. And we need to see the whole concept needs to change. Again, do no harm. There is harm being done. There is no doubt. Now, one of these, if you remember, Tracy, when you were here, you've been to my office many times. This one time when you were here, the group from California that came into my operating room and they filmed me live. They're like, we're going to watch you. They had a cameraman that they hired and they had their own cameraman from Los Angeles. The lady, literally very nice, very thoughtful. She asked me, so what % of the ladies get BII? My answer was 100%. So she's like, okay, what are you talking about? Doesn't make any sense. 100%. There is no such thing as 100%. Then I told her, listen, are implants meant to be in the body forever? Number two, do you know you're going to get silence rupture tomorrow? Or the next time the car door swings open on a windy day and it hits you, you might think that, oh, it's ruptured. It could
or when
rupture
you
on
get a
its own.
mammogram.
Yeah. Or when you get a mammogram or your grandson jumps on your chest accidentally, just like all kids do, or you might cause trauma, or an airbag that might blow off on this lady's chest. The problem here is, and eventually it needs to be replaced. So if it lasts 10, 15 years, now remember, look at all these studies that have been done. The implant rupture rate. Is there any study that says that looks into implant ruptures at 0 to 1, 3, 5, 10? After 10, 12, 15 years max, they stop because they know once you have the implants in the body for a longer duration of time, the chances of rupture go up significantly. So the studies automatically stop recording because they don't want to sell badness. They want to only sell listen. This is the yeah, and again, exactly. And again, I say this very humbly and very professionally, because you know what? If you want to show me the data, show me the 20-year data, 25, and you will find zero because they don't exist.
Right.
So going back to the same point, there is no justification for implants. Yes, a lady has a right to basically, I will never know what it is like to have, breast tissue and how psychologically it is important. But one thing I will say that overrides that is you should not harm the body. Like one of my orthopedic friends, he and I were walking. He's like, so what is she going to do if she has breast cancer? I'm going to say this boldly, melanoma, which is basically skin cancer, very common. If I get it on my finger, the textbook answer says, depending on the grade and whatnot else, you should amputate the joint before. And I said this, sorry, boldly, and again, this is cancer. We live and see and deal with patients every single day. You know what I'm going to tell them? Sorry to be blunt, amputate at the knuckle, at the wrist. I want to live to 120 without chemo, without radiation, and I can live happily without the arm that I operate because I can still be happy. There are people with necrotizing fasciitis, which is the bacterial eating infection of the leg, where they have had to cut both the legs off in these unfortunate patients, right? Or a car accident where, or the sharp nail that blew off the leg, right? And happily, the patient will accept it because that is unfortunately what and how cancer works, right? But in this case, we should not induce it as doctors onto patients because we know it only causes badness in the long run and it's not worth it.
Dr. Khan, have you seen the new implants that are 2 layers of, like the shell is 2 layers? Almost like they put an implant inside another implant, so that if that one ruptures, you're still protected.
You know, people will
That's
come
what I
up.
just heard. It was a Michigan doctor too.
Lord.
Yeah, I know. I will tell you, the people will come up with all. This was there. I removed one, if you remember, not too long ago. If I may, I actually have one that one of the patients gave for research purposes. You know, I actually, I was so the outer side is the saline, inner side is the silicone. If you remember, I did like a Facebook Live 2-3 months ago. The point here is, you know, sorry to be blunt, they should make implants out of titanium because, you know, I have 5 screws here, my hand is not reacted, or the stainless steel. Silicone is a bad material to use simply because, just like I did in the 90s and 92 ban, it leaches out, there is gel bleed, even when you have textured or non-textured, or if you have these what they call cohesive implants, they're still as bad as the ones from the 80s and the early 90s that were banned, and they're still the same problem, and they are not safe.
So I think it was Becky earlier. Maybe I'm wrong. Was it you, Becky, that was asking, what can we do? Like, as the patient? So when I'm in there talking to my doctors, how can we educate our doctors? I mean, you're educated, but our doctors aren't. So as a doctor, how do we get our doctors to listen to us? So is that what you were asking, Becky, or did I not word it right?
No, that's perfect.
So this is a very good question. You know, one of the biggest things that you have to deal with a surgeon is the surgeon's ego, you know? And I say this very humbly, I don't want anyone to tell me what to do. I did, look, 10 years of residency training, 5 years, 2 years of burns, 3 years, 100, 120 hours a week. If you look at after the physical taking care of the patient, I don't want anyone to tell me just because they saw on social media how to do it, right?
Right. That's
Now,
what we're up against.
that, yeah, now this is something where, now if I start talking, I'll tell you, I've been called crazy, I've been called everything that you have been called too, right? Reacting to social media, non-proven science, it's a myth, it is all in your head. This is like my very close friend, he's a plastic surgeon, is like, so you're telling me that I remove implants from a patient and the eyesight improves? He's like,
Yeah.
and you believe in aliens and you believe in everything else too, right? And I say, no, I'm telling you, because don't listen to me. Look at not only 1, not 10, but hundreds of thousands of these ladies who have explanted over the years, right? So we have to, the point here is this, you and I'm going to continue. I told myself I'm going to write and talk about something that I strongly believe in. I'm going to start putting these videos out. I'm going to start putting out whatever I possibly can. Now, look, you know, I'll say this very humbly. You know, we're on a mission. You and I, we have one goal, improve the quality of lives of the better. Now, one thing is for sure, we have to recognize honesty, integrity, professionalism. Number one, the first order of business here is, if a plastic surgeon says, BII exists, I'm an explant surgeon, he or she should not be augmenting, period. The end, especially in 2022. All right, 2012, 2014, it was still kind of up in the air, right? But after these FDA warnings, after all these papers that are now, every day, I will tell you there's a publication, excuse me, sorry.
And
Yeah, so every day there is a, excuse me, every day there is a publication that talks about, you know, the bad effects, the detrimental effects of implants. Now, what we need to do here is this. We need to establish that if you believe implants are bad, you cannot be augmenting. Now, you have to take that leadership role. This is all the plastic surgeons, and say, do no harm, because you never know who's going to get the saline rupture, who's going to get all these problems of what is clearly the FDA is telling you. Now, now I have, believe it or not, I have had a lot of doctors say, so you were not crazy, you know, I see where you're coming with this. You should publish your data. You should write your data. You should present your data. I said, you bet. I'm doing. One of my very close friends, he called me up and he was as sincere as a sincere friend can get. He said, Khan, you're going to get into a lot of trouble. And I said, I like you. You're looking out for me. Tell me. He said, listen, you're putting out information from your OR that everyone negates, everyone talks about. It is highly controversial, and it does not exist. I said, listen, what am I doing is I'm removing the implant, I'm removing the capsule plus any inflamed tissue, and I'm sending the capsule off and taking cultures. That's all what I'm doing, nothing but that. And he said, and the reason I'm doing it, you look at the pathology reports, you get all the badness, the chronic inflammation, the giant cell reaction and all that. So that's essentially, and remember, if this is lymphoma, you have to do whatever I just did from the OR. So he's like, listen, no one can touch you because you are very transparent, you're getting informed consent, and this is slowly starting to like translate into real life, real practice. I just talked to him last week. Now going back to, so no plastic surgeon should be augmenting out of their professional, because imagine what you know, imagine you were operating on a daily basis, you would see these patients on a regular basis. So you would know, just like I did when I was a resident, right, in training. So number one, every plastic surgeon should openly accept BI exists. Look, the FDA is telling you it exists. Don't tell me it does not, right? Number two, the explant surgeon needs to be very sincere in the sense that they should vocally, actively be talking about how they do it. If the four of us go to 4 different, 10 different, 100 different explant surgeons, I will tell you all 100 of them are doing it differently, right? No one's giving the implant back. Someone's rupturing the implant. Someone said, I will try to, I'll do the best I can. Someone's doing it in an hour. They're doing a lift and an enbloc supposedly in 3 hours, right? Which is 2 separate surgeries in what I would say should take 6 hours. And there is a lot of controversy. Now, one thing is for sure, if a surgeon steps up and says, you know what, I am not going to augment and I'm only going to explant, then that is your surgeon, because he sincerely believes, because he has the choice to put in and he's giving that financial reward up because he respects the patient, that's the word to use, and that he will humbly go out of his way, remove all of the bad tissue, send it off to pathology. Now, I will tell you, one of my friends, like, I don't want to send it to pathology because that's the proof how, quote, butchered the capsule was when I took it out. Or they took the, oh, I forgot to take pictures. No, you have to take videos and pictures, right? In order to clearly show, and you have to willfully from your heart accept that BI exists. If you don't accept something exists, how are you going to do the right surgery?
Dr. Khan, can you explain to people watching what BIA-ALCL is, coming from medical professional? Can you explain it to people?
Sure. So BIA-ALCL, it is a breast implant associated anaplastic large cell lymphoma, a direct cause and effect as a result of what are silicone, especially the textured, which has been banned by France a couple of years ago, and also smooth, again, also smooth, that the body recognizes the implant as foreign and hence mounts an immune response. And in the process of doing so, goes haywire and develops what is lymphoma. So now CD30 cells are basically stained, i.e. picked up, that are consistent with what is lymphoma. And hence, complete definitive removal of the implant plus the capsule is the surgical treatment of choice. And any abnormal fluid that is usually associated with this lymphoma must be sent to cytology for analysis to rule out lymphoma.
And so where do you find this fluid? Is that fluid found between the capsule and the implant? So that's
correct. That is correct.
That's the big reason
maybe
why.
Even maybe in the proximity or outside.
Oh, you can find it outside the capsule as well?
Right. And it so majority, now remember, to date, as we speak, if you look at the literature, 733 cases exist on Earth so far. Now, this is according to the FDA and the many other cancer societies. they clearly state this is way underreported because not everyone is sending the capsule. And this is where I say, if you don't send the capsule, you're not going to know what you're dealing with.
Right.
Well,
Right.
Dr. Khan, we actually have someone on our live feed is asking if my breasts have become larger through the years, could that be a silent rupture? She said she had silicone implants almost 10 years.
Right,
So
right.
could that be a symptom of the breast getting larger of either a rupture or BIA ALCL?
So that is a good question. That is in the differential. Now, remember, it is relatively rare or rare, right? Now, I will say this to you, just like I was saying, 733 women to date have had BILCL that has been reported by the FDA all over the world, not only in the US. And this number is way underreported simply because many people do not know how to test for it. They're not looking out for the CD30 analysis. And if you don't test for it, you won't know what it is, right? Not only sending the capsules out, but sending it for the appropriate markers and the appropriate fluid. Now, going back to, now, if you go back and look in the 10, 15, 20 years ago, what did the FDA require? Now, this is homework that I want Becky, Dawn, and Tracy to look into. The FDA said this. Believe it or not, this is in the literature. This is the recommendation. Any lady who has silicone implants should get an MRI at year 3. And then every 2 years, they're onward looking for potential rupture.
Wow.
So,
Okay. Yeah. So this is where now I will tell you, unless you do an MRI, now this is the best imaging test, MRI without contrast. You will never know by exam if this is a rupture or not. You may have inflammation as a result. You may have a contracture as a result, right? Where the body is swollen. Most of the ladies, as you will know, you will have green dilated veins, for example. That's the reactionary tissue. The MRI is the best test, not a mammogram, not an ultrasound, not a thermogram, none of this, not a physical exam even, where you will clearly be able to prove. Now, remember, as you will see from my Facebook lives from the OR, sometimes the MRI still has been proven wrong, but the MRI is the best test. So I would recommend to this lady, go get an MRI without contrast so that we can get the best study that exists still in 2022, which says specifically rule out rupture of implant. And this is where you will see the linguini sign. You can Google this actually, where you see false intracapsular rupture. I saw a lady yesterday, she had an MRI that shows intracapsular rupture on one side and extracapsular rupture. And we can look at this given the MRI findings, if she has rupture or not. And ultimately, the only true way is, and this is a very important point, till you do the enbloc and you cut the capsule open and then see, only then will you find out if it was a rupture, yes or not, 100%. MRI being the best test imaging modality out there to at least going into the OR knowing what is potentially going on.
so what about people like me that I had the textured for 12 years and then I didn't know about breast implant illness back in 2010 when the rupture happened and I had them replaced with smooth, but I had the textured for 12 of those years, the ones that have been recalled. So my surgeon probably didn't know anything. He removes them and puts new ones in. How do I know that I didn't have BIA ALCL? How do I know that I'm free and clear? Can that come back and bite me down the road? Because I thought I just heard a gal ended up with it 6 years post-op.
Right,
So
right. So this is
I'm
actually,
nervous.
this has been, no. So I'm going to say this to you. I'm learning just like you are. And now I need hard evidence, right? There is actually a report. There is a case report that I saw where a lady removed her implants, capsules were left behind.
Oh, okay.
And then 4 years later, she had lymphoma. And
Oh,
she had
okay.
implants because of the residual capsules. Now, could she have had lymphoma at that time?
Yeah.
Guess what? There was no fluid, but because it was not tested. Now, sometimes when lymphoma happens, you can check the blood. And I'm not a lymphoma expert. I'm not a medical oncologist, but it will show up in the blood. It will show up on the exam, and the lymph nodes will light up in the axilla. And remember, any abnormal palpable lymph nodes in the axilla, you're always thinking breast cancer because 1 out of 8 or 9 women are going to get breast cancer. And you always, if the patient has had basically implants, even if she has removed the implants and she has palpable lymph nodes, the differential is also lymphoma, period. Till you biopsy and send for CD30 analysis and rule out lymphoma, the differential always exists. And so this is where, when I share the pathology reports with my patients, I tell them CD30 analysis, and look what I write in all the pathology reports. I tell the pathologists, and I've talked to each one of them and they know me, rule out silica, rule out breast cancer, rule out BIAL, CL, CD30 analysis. Look at every pathology report. You're going to see that clinical information provided by me officially on paper to the pathologist. And they know better. I told them, I want you to go ahead and rule out lymphoma. I want you to do the CD30 analysis, because if they're, now I sent this to another lab. One of the patients said, well, I have a contract with Quest. Now, the Quest doc said, oh, it does not know breast cancer. Then they didn't check for CD30, right? So that's important that the lab knows and checks for something that if the mind doesn't know, the eyes basically will not see it.
Okay. So basically I really shouldn't worry. It's probably because she left capsule behind.
So if there is a certain risk, but if your exam is
now, that's what
benign,
we're
and
going
yeah. And so, and again, this is again going back to these few case reports that I've mentioned, residual capsules have led to, but is this an alarm? But at least the burden of the implants removed. Now, more research needs to be done, more analysis to conclude that definitively. Now, this is a big deal that textured implants were banned by France, and then ultimately Allergan was asked to recall, not recall, excuse me, that's the wrong word. Allergan was asked to basically take them off the market, and the plastic surgeons were mandated not to put in textured implants. It's illegal, your license will work. There was not a recall. They didn't tell those ladies, go back and remove the implants. So let me tell you this again, going and living in the Motor City, you
Wait,
have a
so
bad
it
car.
wasn't technically a recall?
No, it was not. So this is clear. I want you to hear me out. If you have a bad car, what do these big three or any of the overall, the big motor companies say? Bring your car into the dealership. We're going to change the airbag system.
Yeah, they
And
fix it.
they fix it for free of cost. They fix the brake of the car. They called me. When I was driving a rental one day, they told me, don't drive the car. We're going to send you another car to where you. I said, I'm not going to come and give you the car because I'm just too busy. They said, we'll send you a car on a tow truck. We'll get this car from you, but you cannot drive it.
And if
Now,
you don't respond, they keep hounding you.
Right. Now, this is what you see. They're afraid
That'd be
for you
nice.
because you're going to get into an accident and the burden's on them. Right now, this is what you call is a recall. Now, with the textured implants, what happened was, if you have textured implants, don't worry, live happily ever after, but it's moving forward. These implants will not be placed in the patients. They didn't say if you have, now they also, FDA, told Allergan 10 months later, I want you to look into this too, very interesting. Hey, Allergan, did you reach out to the 52,000 patients who had textured implants? Did you follow up? They didn't tell them, go tell them you need to get them out and get them replaced or removed definitively, right? They said, now you would imagine the insurance companies would now step in and say, you know what? Oh, they have been banned. So now we should at least cover them, right? Because it's not the patient. No, the insurance company said, not our fault. We're not responsible for this. And neither did the FDA push the insurance companies to pay for a removal of textured implants, and the many thousands of ladies who have them and who want them removed because they feel like I'm walking around with what is a banned implant.
Yes, another thing that we need to change. So many women aren't getting this surgery because they can't afford it.
Yes.
Right. And so another thing I want to mention again is, oh, I love my plastic surgeon. He's going to do it through my insurance. The reinsurance, the number one reason for bankruptcy in the United States is medical bills, number one. Number two, the reimbursement for a explant, i.e. a capsulectomy, number one, insurance is going to say, who told you? Who's the wise guy who's telling you to remove the capsules? Because this is voodoo, myth, and it's not the standard of care. Removal of the implant 3, 5, 800, 1200, 1500 max, and it will not justify what I would say is going to be a 4-hour operation. So anyone who says, I'm going to take your insurance to remove implants, 100% is not going to do the right surgery, because that's going to be a recipe for Chapter 11.
Can you talk about lifts, Dr. Khan? Like
Yes.
there's a whole bunch of doctors doing enbloc with lift at the same time. You're one of them who will not. There's a whole bunch who will not also. Not making it sound like you're one, the only one. There's a whole bunch who will not do it. Do you want to talk
Good.
about that? Why?
Yes. Now, if you look, vast majority of the implants are below the muscle, right? And you will see most of the breast tissue is, the breast tissue is above the muscle and the implants are below the muscle. So the goal of the surgery is to remove the implant capsule and remove the inflammatory burden. Now, in the many 30, 40, 50-year-old ladies, and even a few 60, where you have tissue elasticity plus the recoil capability of the breast tissue will go back. Now, if you look at a surgery, so essentially in many of the young women, it's not required. It's too much surgery and unnecessary surgery. For someone who loves to operate, if you ask me what would I do on a day off, I would love to operate. I would never do any unnecessary surgery, especially in someone who does not need it. Number two, if you look at a lift, let's say a lady comes to me and she has no implants and she says, I want a lift. Just to do a lift in someone is a 3-hour, 4-hour operation. Now, there are many types of lift. There's like this J lift or S lift, concentric lift. Now we're talking about the lollipop anchor incision, where you literally do a mastopexy, where you rearrange the tissue, the skin, where this is relatively speaking an involved operation. Now, look at me. On average, I take 4 hours to do what is an explant enbloc in the right etiquette, where every single time I walk out of the OR, I tell myself I could not have done the surgery any better. And like today, look, I finished my second case at 4 when I did my Facebook Live. There are many cases where I've done where I'm going into the OR at 5 p.m. for my third case, because the first two just took that long. And the point I'm trying to make here is going back to your question about a lift. The lift is
risks,
all above.
right?
Yeah, it's all above. You can get nipple necrosis. There is sometimes capsular contracture. There is asymmetry. You do not know how the breast tissue is going to recoil. So now there is risk for asymmetry and a surgery that's number one not required, nipple necrosis, skin necrosis, wound dehiscence, wound breakdown, and plus the length of time it takes to do an enbloc definitively, completely, plus a lift, which is all above the muscle, is separate. It should be a 6-7 hour operation, and you don't want the patient on the OR table for that long period of time. It has been shown conclusively patients who are undergoing surgery, after 6 hours, the risk for DVT, infection, seroma, hematoma, all of that goes up simply because of the length of time the patient has been on the OR table.
Okay.
We have another question from one of our live viewers.
Yes.
She says, so if you have thin capsules, is it possible for a surgeon to get it all out? This is what scares me.
Yes. So there is thin capsules and thick capsules, capsular contracture. The thin capsules absolutely can be removed definitively, comfortably, because I or whoever that plastic surgeon is actively looking at them. The capsules are thin, but they are certainly very much present, and they can absolutely be removed definitively. They are not so thin. Look at how many capsules I've removed where they're so thin you can actually read through them, right? What could be thinner than that? And they absolutely can be removed definitively. No one can say, well, the capsule didn't exist. Now, there are times where the capsule is so benign and so basically like benign appearing, it has no consistency to it, right? But still, it must be removed. Now, this is where I say to you and to that listener and to everyone, unless you send it off to pathology, but grossly, you have to analyze. And there are times where I look at the capsule and there's inflammation present.
Okay.
So hopefully that
Thank you.
answers the question. You have to send the capsule off to pathology because the capsule inevitably forms around any foreign body in the body.
All right. Thank you.
Are you welcome?
Also, I've seen women, like I wanted a lift. I thought I needed a lift. I don't know if I did or not now, but you see them and they bounce back and they look pretty darn good like a year later. So the whole waiting, I know it's hard though, because you can't afford 2 surgeries. For the most part, we can't even afford this surgery to remove them and save our lives. And then you don't want to end up, looking bad. That's the whole reason we got the implants, the beautiful breasts that you're getting rid of. You know what, a great question for you, Dr. Khan, is both of these ladies here have had a complete flat closure, and a lot of doctors are not skilled at that. And I guess it is a real skill. And I didn't know that. Like some of these women are told that they're going to come out with a flat closure, and that's not what's happening. And do you do completely flat closures if they request it?
Yes, absolutely. By definition, the mastectomy patients inevitably will get a flat closure period. Now, there are patients that I have done who have had mastectomy, but they had deep, or which is a deep inferior epigastric perforator flap or a latissimus flap, or this one lady had a thoracodorsal flap. So you want to preserve all of that blood supply, especially to the radiated tissue. But essentially, any lady who has had a mastectomy with implant reconstruction thereafter will only be flat chested and nothing but that.
What about
And
somebody like me? What if I still had my implants in and I just say to you, you know what, I'm done with this. I don't want the risk of breast cancer down the road. Just take them out and close me up flat. Do you do that? Or does it
so,
have to be a
so
breast cancer patient?
no. So that is a very good question. Now I'm going to say this to you. For me, unless you have the BRCA gene, right, where you know you're going to get breast cancer, my recommendation and suggestion is this is not the time to do a mastectomy.
Okay.
Because whenever a mastectomy is done, I say to you, you have to get a sentinel lymph node, even prophylactically. So I'll say
Have
this
to
again.
what?
You have to get a sentinel lymph node biopsy, which is basically to confirm that if that breast tissue that was removed, there have been sometimes incidental findings of what is breast cancer. Remember, 1 out of 8 or 9 women are going to get. So this is, you have to have had a mammogram, a workup. God forbid you did a mastectomy and the lymph node was positive, the sentinel, the first lymph node that drains the breast. Now, you don't want to basically make it more complex by doing 2 surgeries in one, right? Now,
So it's similar to doing a lift. You wouldn't want to remove the breasts and the implants in one surgery.
Right, exactly. Because you want to focus, the goal of the surgery is to remove implant capsule, all inflamed tissue, such that now I will tell you, this is again going back to the lift question, Tracy. Imagine this is, if I may, this is the rib. This is where the implant is sitting. Then you have the muscle. Then you have the breast tissue and the nipple areola. Now, if you have the implant that's causing all that inflammation underneath the muscle, once you remove that and the muscle then sticks onto the rib cage, the breast tissue inevitably recoils, especially once the inflammation subsides. Especially when I have my patients, as you all know, wear a compression bra along with a binder that gives them a small recoil. And that, as you will see, helps the vast majority of the patients. So many of them are surprisingly very happy, and they are very much like sometimes even shocked, as you have heard, when they see themselves and say, wow, I didn't even lift and look where I am, right? Especially the young ladies in their 30s, 40s, and even 50s, as you have seen. Now, going back to the tissue itself, the skin recoiled, believe it or not, almost 40%, 30 to 40% full. The breast tissue itself also recoils, as you have seen, especially when it's not inflamed. And the bottom line here is we have to give that a chance to settle. And then, if needed, get the mastopexy, if you certainly do so desire. That, remember, any mastopexy will last you 10, 15 years on average. After that, you will need another one, because with gravity, it was going to only start to droop again, especially when the ladies hit the menopause with the estrogen, progesterone gone. So going back to, the goal of the operation is relatively simple. Now, the other thing, if I may mention, going back to the mastopexy, what is the mastopexy? It's all above the muscle. Remember, the explant surgery enbloc in the vast majority of the ladies is below the muscle. The mastopexy is all above. Incision all the way around the nipple areola, and then all those markings, the M markings, and then to lift the nipple areola up and cutting through. Now, when this lady goes and gets, for example, a mammogram, there might be some scar tissue, or she might palpate something that might be fat necrosis that inevitably can also occur as a result of a lift. So a lift is not a benign operation in itself, but certainly in many ladies, I will say if they're in their 60s, 70s, or if they have had significant weight loss, an operation that is justifiable and very much, a real operation where the patient will feel aesthetically pleased. Now, one thing I will mention here is fat grafting. We didn't talk about this, is a very dangerous operation. Now, on the face, as I do not know if you've heard me, but for the many other listeners, on the face, fat grafting is a real solution to what would be rejuvenation of the face, where you take 1, 3, 7, 9 cc's of fat and basically in a web fashion, put it especially in the cheeks and in their respective areas where you have a permanent filler, where using the Coleman technique, 30% of the fat is going to inevitably die, even in the best of the hands. You now take maybe 70, 90, 150 cc's, and just for basically completeness sake, that's almost less than half of what a Coke can would be. And you inject on the chest, on the breast tissue. And guess what? I guarantee you, we know this from the face, 30% at least, I would say 50% of the fat is going to die. Because remember, the best supply is on the face. Now the young lady, the young mom in her 30s and 40s or 50s or 60s, nowadays 70s is, I have surgeons that are operating in the mid 70s still, right? They feel these clumps. Is it breast cancer? Is it a precursor? It's scaring me. Is it whatever it is? Now they get a mammogram, it's inconclusive. They get a biopsy, it's inconclusive. And now there is fear of what is 1 out of 8 or 9 women who are going to get breast cancer statistically, right? Mm-hmm. And unnecessary anxiety. I'm getting anxious just talking about it, right? So fat grafting is not a smart idea. It's a foolish idea, sorry to be blunt. It is something that will only cause a lot of red flags later on, as fat necrosis will inevitably occur, even in the best of the hands, for a very small volume, 70, 90, 100 cc's, if it even takes, right? For something that you will require serial fat grafting. And this is something that I will tell the ladies, it's not worth it, again, simply because of the risk of breast cancer.
I was going to have them do it. And then I got on the support pages for fat transfer to the breast, and I changed my mind. One, I don't handle pain well. And they were all talking about honestly, how painful it is to get the fat from where you want it and put it there. And then all the risks that you had just mentioned.
It's the most painful thing I've experienced. I had it twice during my reconstruction because, again, I was small framed and they said it's just going to be a couple implants in there. We got to do this fat grafting. I will tell you, it felt like the most barbaric thing I've ever had done to my body. And I will also tell you that most of that, if not all of it, failed around my implants, where the only place that the fat grafting worked at that time, they really kind of hacked my armpits. And they had to put fat in there because it was like a cavern. And that I do have very voluptuous armpits, I will say. But on the next note, I had explant, and like I was saying, I had a different case from the start from my cancer. And so I had all that adhesion, and my skin literally had like no innervation, no fat between my skin and my ribs. You could see everything beating in between every rib. You could feel my heart. And so a couple pokes to my chest, and I said, you know what? I'm doing this fat grafting. One, I felt like my skin was dying and it was getting necrotic. And 2, I felt like in my garden, I was going to actually puncture a lung or a heart issue, just hitting something because there's nothing there. So I did this fat grafting to save myself more than to build up breast tissue. And I will tell you that once again, the first fat grafting, I basically got a little layer of fat between my skin and my ribs, which was the goal. And I did have innervation I had warmth, and I had color again.
Wow.
The second time, they put more in there, and now I do have coverage between my skin and my ribs. But I could tell you that, you know, I had total confidence in my surgeon. I love my surgeon. I have Ehlers-Danlos syndrome as well, which is a connective tissue issue. I am still bruised. My thighs are still bruised from the fat grafting procedure done in June.
When I had mine done, I
Yeah.
couldn't sit without pain for 6 months.
No sitting, no
It was
sitting
the-
on the toilet seat.
It was the most
months.
painful thing I've ever been through.
Mhm.
Yeah,
And
so
not
I
only,
agree.
not when the fat died and I got the fat necrosis, not only does it feel lumpy, but it looks lumpy. So I had this permanent looking cottage cheese around my implant. So yeah, I would say not worth it at all.
No, I'm scheduled for an ultrasound in March because of all the lumps in my chest. And I hardly have any fat grafting done. And, you know, for other people to say, oh, you should just go ahead and do more fat grafting. No, run. Unless you have something, I felt like it was essential to save my tissue. I would not tell anybody to try to build their breast tissue up with fat grafting. I think it's kind of a barbaric process to your body. And like
And
I
there's
said,
a lot of risk.
all that's left are lumps that feel like my cancer lumps that I had prior to my mastectomy in the first place. So
Yep.
it's things to think about. I agree,
Right.
Dr. Khan,
Sure.
Becky, Tracy.
Yeah. Now, Dawn, I
Not
will
the road
tell
to
you.
go if you don't have
Yeah.
to go.
Dawn, I had the privilege of meeting you in person at my Novi office, you know, and I will tell you again, I remember your story about how BII hit you pretty hard at your young age, especially with the blood pressure. Now, if you can just talk about it, because this is a very nice, you know, I did a Facebook Live with Dr. Shafiq, who's a cardiologist, who sent me a patient with blood pressure. And I was like, oh my God, a cardiologist sending me a patient for removal of implants. Who's this genius? I need to talk to him. And I just wanted to pick his mind and see. I want you to please share with the listeners and the viewers, if you don't mind, which you have done before, what your symptoms were and how you rebounded from your BI symptoms.
I had like all the symptoms plus some. But like you said, one of my biggest ones was my chronic hypertension. And it came on immediately when I had my expanders and my chemotherapy started at the same time. And it just kept on escalating. They'd add a blood pressure med. Okay, now we're going to add another blood pressure med. We did renal artery exams, ultrasounds, CAT scans, couldn't find anything, kept on going up. So I'm on 5 different blood pressure medications where
Wow.
I usually had almost abnormally low blood pressure. I've been an athlete my whole life. And so I had my explant, not thinking that my blood pressure was going to actually get better. You know, oh, that's not your implants. So many people said many of these problems were not my implants.
Mhm.
And the second surgery after my explant, they had to give me a couple injections in recovery because my blood pressure had dropped dangerously low. And they said, oh my gosh, you're on these 5 blood pressure medications and your blood pressure is so low. Well, at that point, along with my cardiologist, I kind of took myself slowly off my blood pressure meds as I had been put on them and went down to the Sentinel and got with him. And, you know, he's not really happy about me just getting off my blood pressure meds, but I've seen this movie before in different aspects going up and down. And long story short, you know, it was about 6 months afterwards. My blood pressure now is usually it's about 120 over 60, 70. I'm on 1 dose of lisinopril. Like I said, I was on 5 different meds. And Dr. Khan, when I had last seen you, I was still having palpitations of my heart quite often. And I was wearing a regular heart monitor. And I will be happy to tell you also, a year and a half after explant, and confirmed by those monitors, I no longer have any heart palpitations at all. I have very small atrial and ventricular flutters that they said there are nothing like these palpitations. And you could see your heart just coming out of your
Wow.
chest, gone.
Now,
So
I will tell you, no, and this is amazing because you know what? The lady that I did today, the 1200 cc implant, her major complaint was the heart palpitations. And hopefully we'll hear from her if she wants to disclose, you know, and this is what I would say, kind of atypical. How many women walk in with this? Now, let me ask you this. What does your cardiologist say now?
Well, you know, he said before, you know, you don't see this. You don't see people get off 5 blood pressure medications.
Right?
You
It's
don't
unheard of.
see
Yeah.
a 210 over 110 average. I mean, my blood pressure was horrible. When it was lower, it was like 189 over 110, 100. And that was my good blood pressure for that 5-year period that I had my implants in. So it was, I'm lucky to be alive, and I'm so thankful that I got my implants out, even though they said it wasn't that. Lo and behold, it was. You know, all the horrible aroma I had, I would call it aroma,
Yep.
that was gone the day of. I had shingles 2 to 3 times a year. Explain that.
Wow.
Gone after explant. I have not had shingles since explant in 2019.
Wow.
And it goes
So
on
it
and on
reminds
and
me,
on.
you know, your story reminds me of this nice lady. So Tracy Gary called me. I remember it was uh and she said you
Oh,
really have to
Ashley.
go. Yeah, you really have to go to this nice big hospital system. This nice young lady in her mid-30s. She's on 5 blood pressure medications. I actually
She
went
might have been
there.
on
Not as a
7.
Yeah, yeah.
Oh,
I went and she was in the ICU. They literally got a pulmonologist, allergy immunologist, cardiologist, every single person. And this is one of the major medical centers of the United States. I won't
Told her
mention the
dad to plan her funeral.
Yeah.
yes.
They
And
couldn't figure out what was wrong with her.
right. And what is interesting is, you know, Tracy told me just go. And I went there not as a physician because I don't have privileges at that one specific hospital. And I went there because I talked to the dad who went home a few days before and literally got all the evidence, paperwork on BII, and was trying to educate all these docs who kept looking the other way and said, he's crazy. Sorry to be blunt. This is not BII. This is nothing like this. We know we are all specialists. This is something we do not know. They did all the pheochromocytoma, all those studies, everything single imaginable. And it was everything but the implants, unfortunately. And anyone who looked at it, and the chief of plastics is a friend of mine, he even said, disclosed, well, all literature points towards the safetiness of the implants, and it is not that, and we're not going to risk her life removing the capsules because it is not worth it. And I will tell you, this is something where, you know, and again, this is where you have the greatest minds in that hospital or in on this one patient, but unfortunately the same 5 blood pressure, and we are talking IV medications. We're not talking by mouth. She is admitted to, now, if I'm not mistaken, she even stroked out. She had a stroke.
She had a stroke and was paralyzed on one side, and they told her you'd never regain anything again.
Yeah, and God bless her soul, the nicest dad you're gonna find.
Oh, yeah.
Very resourceful. And you know, you know, the point here is things like these happen, and it is the implants, it is the implants, it is the implants to prove otherwise.
Well, she's now the person who was never going to regain any feeling or anything on that paralyzed side is now up and walking with a cane and driving a car.
Wow.
She's walking with a cane and driving a car. She's not in the ICU. He was told to plan her funeral. And he said,
And
do you think it's her implants? And I said, well, I don't know. I
Right.
don't have a crystal ball, but if they can't seem to diagnose her, you have nothing to lose except her life. You know, I mean, if you don't do it, you're doomed anyway, according to them. And they removed him, and she's now up and walking and
Wow.
lives at home. Yeah.
I think that
So
goes-
many have been
and
tested for
30
MS. I
mid-30s,
know
mid
like a
30s.
dozen of us just in the area I live in. People have been tested for MS because we've had symptoms of MS and had the MRI and it didn't show MS.
And
thank
I
goodness.
think that goes to show that I saw 9 specialists when I was sick, trying to figure out what was wrong with me. Just doctor appointment after doctor appointment after doctor appointment. And each one either put me on different meds or wanted to put me on different meds. And I think it just goes to show that these are not bad doctors. These are specialists. These are really educated people. But a lot of these specialists just don't know about BII.
Right.
So as women, we really have to listen to our bodies. And I love that the word is getting out, because the minute I heard the words breast implant illness and I clicked on this article and started reading through the symptoms, I knew exactly what was wrong with me.
Mhm.
From that minute, in my heart and in my soul, I knew it was my implants.
You're so much smarter than me. I ignored it for 6 months.
Mhm.
I prayed, God, please tell me what this is. Show me, give me a sign. And he gave it to me and I ignored it for 6 months. I kept ignoring Annette and she's like, it's your implants. And I'm like, there is no way it's my perfectly safe saline, gorgeous boobs.
Mhm.
It
Now,
was.
Yeah.
now what we need to do is, as the leadership role that we have, we need each one of us to discuss, and this is kind of the question that you had asked earlier. We need to, number one, write about our experiences. Write, in a sense, discuss Facebook, Instagram, TikTok, whatever it may be. Number one, we need to very sincerely, one by one, reach out to these what are very professional, nice docs who understand their specialties like rheumatology, allergy, immunology, endocrinology, that you certainly will have altered endocrine function, thyroid function. Look at that big MD Anderson study. We need more publication studies, people, and now, as you will see, slowly there is more and more recognition in the literature, the medical literature, because it's at these conferences where one doc needs to actively mention, once the implants are removed, that the blood pressure is improved, the rheumatological problems, the ANA, the rheumatoid factor is better. These Lyme disease so-called problems are indeed breast implants and not Lyme. And this is, again, you have to go through the battery of tests. And I think, look, where we were 3 years ago, look, the FDA was not even mentioning or acknowledging. Now I say this to all plastic surgeons, my colleagues, my friends, my brothers and sisters. You know what? BII is real. We need to step up and say, you know what? Let's put a halt to the augmentation. Let's just explant right. Let's send the capsules off. Let's take the cultures. Number two, we need to get the FDA. Then now, if you have recognized, where clearly the FDA has recognized the BII exists, we need to get an ICD-10 code so that we get this disease recognized as an entity in itself, and that there is financial reimbursement for the many ladies who simply cannot afford what is involved surgery, so that just like any other illness, it gets its due right and its due treatment, and that there are collaborations, discussions, not only from the plastic surgeons, but from the manufacturers, who basically share their data that they have over the years, and data which is hard evidence that clearly shows basically what and how these saline and silicone implants behave within the body, what the pathology, electron microscopy, and all these other studies show. And clearly, we should put a halt to the augmentation. The ladies should, I say this to you wholeheartedly, at least after this FDA warning, only to be going to those surgeons who have a track record of removing the implant capsules safely, definitively in the enbloc fashion, or 100% total capsulectomy. And that the last thing any of the patients that want to hear is the fact that their explant was done, but guess what? Part of their capsules were left behind because the surgeon thought it was better, safer, healthier for her to not remove those residual capsules because of the risk for pneumothorax or something that the body in itself will inherently take care of it itself, which is not true.
There's somebody named Debbie Jewell that's asking, where can we go for heavy metal testing and what to do, or what do we need to get after explant? I know there's all kinds of detox pages, Debbie. But do you guys know anything where you want to lead?
For me personally, because I had cognitive issues, my general practitioner is the one that ordered one of my heavy metal tests, which is a 24-hour urine test. And it doesn't test for all the metals that are in silicone or the breast implant capsule or the actual shell. But it does test for quite a few, and because I had arsenic, lead, cadmium. There's another one in there too, but what's that?
Nickel?
Nickel wasn't, I didn't have nickel, and I didn't have mercury, which was a nice surprise since I worked in dentistry over 20 years. But there's another one that tests for the other things, and I think it's a hair test where you could get that at some of the holistic practitioners. I'm not sure of other places to do that, but the hair test seems to be the one that picks up like platinum, the other metals that aren't on the urine test. So that was my experience with it.
Right. Now, this is, more work needs to be done. You could be living in the Gulf region. You could be living in Flint, drinking, lead water, if you will. And again, I'm just mentioning, you could be eating from a tinted sardine, can. And again, I'm just basically mentioning there are just being the devil's advocate. Now, getting a heavy metal test, what is going to be the treatment? What is it now? Is this a diagnosis of BII, right? No. Ultimately, if you ask me, the ultimate way to tell and gauge is this, where, and again, I'm learning from Henry Dykman, for example, Dr. Henry Dykman, who said that you do the electron microscopy and energy dispersive x-rays of the lymph node tissues, for example, right? If there are any. And what is the significance of doing these tests? Because they're not going to be able to convincingly say, well, this came from this implants or this came. Now you look at just the ingredient list of the implants, you'll see all the heavy metals on earth, literally, with one manufacturer being different from the other. What is that going to show, right? Especially if it's done through the hair or the blood. Now, what does it translate to in real life? Things like, for example, taking vitamin C. Now, if you have an orange or a lemon per day, that vitamin C level that you ingest should be enough, unless you have metabolic disorder where the gut is basically not absorbing. Now, there's so much variation. Look, there are patients of mine that have stated clearly 6 months later, they can now eat ice cream and cheese pizza, which before they could not even look at, right? Because their gut reactivity is not what it used to. Now, it takes some time for it. Now, the body itself, there's nothing, i.e. as a physician that I know of, that body will consume that will make it healthy or better, other than what is organic food, non fructose or basically high calorie sugar type of food, right? And again, eating healthy, you are what you eat, and making sure diet and exercise basically is all good, non-oily foods, not the food that has basically the growth hormones, the estrogen, progesterone, whatnot else. And again, the point here being, to answer the question as a physician, as an MD, heavy metal testing, what will that ultimately lead to, right? Is there an antidote that they're going to ingest? Like, there was mentioned by one of the patients that there was charcoal that she took, but that's in reality is someone who goes to basically a suicidal phase where they ingest, let's say, 100 aspirins. You want to basically, or this is again what the emergency room docs do in order detrimental effects of the poison. And again, I do not understand or do not know that is not going to collect the heavy metals out of your blood, right? Now, Dr. Atul Mehta out of the Cleveland Clinic mentioned that he had a patient of his. Now, this is a Facebook Live I did with him, a saline implant patient. Again, Tracy, very interesting. Becky and Dawn and everyone else who's listening. A saline implant patient had ground glass opacities in the lung. He, as a pulmonologist out of the Heart and Lung Center, the #1 in the world, as a transplant pulmonologist, did a biopsy only to show that there was silica within the lung tissue.
Oh my
He's
God.
published this with
That's
a
frightening.
doc of the UT Southwestern. So this is Cleveland Clinic and UT Southwestern. This is again Dr. Atul, A-T-U-L, last name M-E-H-T-A. He did a Facebook Live with me. Now, I asked him, this is Facebook Live, how did that silicon make it into the lung? And he said, through the blood. And I knew the answer because this is where it goes in the lymph nodes and the tracks into the blood. And then it deposited into the lung for this one specific patient. And he showed it by a lab in Buffalo, electron microscopy, and energy dispersive x-rays, just like what Dr. Henry Dykman did, clearly showing this is the silica from the implant.
Wow.
And when this patient underwent plasmapheresis, which is basically filtering of the plasma to detoxify the body. Now, I do not know much about it. I learned from him that day when he mentioned this. The patient improved over the course of the year. These are his exact words, and he wrote this. The point being here that the silica migrates within the bloodstream to the rest of the tissues. And we know Dr. Henry Dykman's analysis of the soft tissues, the nerves, the spleen, the brain matter of this one patient who had a ruptured silicon, that the silicon was replete in the whole body. The point here is these heavy metals are present diffusely, and how this can be leached out of the body in a patient who has had ruptured silicon or the many signs symptoms of BII by detecting these heavy metals, maybe, maybe not. We know they exist, but what is the treatment? What is the antidote? What is the way to get the silicon out of the system where it has spread to the neighboring lymph nodes? I do not know. Out of that patient that had it in the lungs. Now, I would tell you the giant cells of the body, which are the macrophages, the cleaner cells, they themselves process and eliminate this debris, right? As we see in the many pathology reports. And the goal here is, as we move forward, more research needs to be done so that we can treat this effectively, not only by explanting definitively by removing all implant capsule plus all inflamed tissue, but hopefully another way where all this silicon that has leached out these heavy metals can be chelated, if you will, and removed, eliminated from the body.
Annette just posted, she's an ER RN. Wow, ground glass opacity, is that how you say it?
Opacities, yeah.
Are what show up on the CT scans with COVID.
Interesting.
Yeah,
Wow.
COVID is an interesting problem. You get all the fibrosis and COVID, and again, we see this in many disruptions of the lung. So it's a non-specific pattern, but a pattern that Dr. Mehta reported in his case study.
Okay, we're going to throw some questions your way because there's 112 comments that, at least on this page, if you could answer them quickly. Renee Fields wants to know, have you ever gone in and there's no capsule?
No.
Okay.
There are times when going back
Start
to there's
scouring,
always
girls.
yeah. So there's always a capsule available.
Okay. You guys see any questions? Could this be why I have nodules now in my lungs? Sounds like it's possible, right?
You know, when you have nodules in the lungs, if we, when I did my general surgery, there was an incidentaloma clinic where the patient came in for a CT of the abdomen and pelvis, for example, the belly, and they did a scan of the lower part of the lungs, and they found some nodules incidentally. Many there are reasons, many reasons for nodules. Could be TB, could be hematoma, could be a benign mass that's basically collapsed on itself. These nodules need to be followed by a thoracic surgeon, maybe with serial ultrasound. If it looks suspicious, MRI, a thoracic surgery consult, maybe a biopsy. So it needs to be fully evaluated. But as you will see, clear evidence of what are silicon granulomas within the chest that have been reported in patients who have had ruptured silicon.
Okay. And we have Cassandra Watkins joined in the wrong time zone, but she's here now. But that's okay, Cassandra, because you can catch the replay. She's also asking, do you do lifts at the time of total capsulectomy and explant? We already answered that, but when she goes back and watches, he does not do lifts at the time. Do you do muscle repair in all ladies with under the muscle implants?
When you came to me, one of the few times, you and I just did just like you did very nicely. You set this up very nicely, Tracy. There were two other ladies that I had operated on, and we talked about the lift. So there's a nice YouTube video featuring Tracy. And so please look at that. That's a good one. Please, if you can repeat the question, this last one.
Here's one. Rachel Umphrey, can you explain why you don't use drains? I thought they helped to prevent hematomas, etc.
Got it. So very important question. Please quote me on this and check and balance on me. A drain will not prevent a hematoma. I'll repeat this again. A drain will not prevent a hematoma. Whenever a hematoma occurs, it's an arterial blood, usually under high pressure, that all of a sudden, be it in the chest or in tummy tuck or wherever it may be on a facelift, it will form a clot. That clot will not drain out because it is like a jello, if you will, consistency. So a hematoma will not drain out. Now, a drain will prevent a seroma, which is the fluid, the serosanguinous fluid, it's more watery, that will leak out, especially in a lot of inflamed tissue. Now, if the surgery is done right, and look at all the videos, the YouTube, and now as we move forward, Becky was mentioning this, how I was dissecting off of the rib. It's essentially, it's a bloodless field. I'm in that avascular plane, literally millimeter by millimeter. I'm dissecting in that very nice plane where their blood loss is essentially minimal. I'm not leaving any inflamed tissue. I'm not, quote, lack of a better word, butchering through the muscle or the breast tissue or speeding through the surgery. The need for the drain does not exist. And I, as a board certified plastic surgeon, I feel strongly I do not need to place one. And look, last year I placed 0 drains. Now there are some ladies, for example, that did have a seroma, but the amount of fluid that does form in itself will get absorbed by the body. And so the need to drain one, if it does exist, maybe might occur in the radiated patient or in the patient that has a low BMI or the patient that has had a 800 cc large implant, a large area of dissection. So to answer your question, if and when the surgery is done right and there is no gross spillage of silicone within the chest, the indication for the drain is not there. If you want to check if there is any spillage of any silicone within the chest, there is a big inflammatory response. So if that slime spills into the chest, that automatically mandates placement of drains till the output is less than 30 cc's and less. So hopefully that answers the question.
You said 1200 was the implant you pulled out earlier today, right?
Yes.
Just to put things in perspective for those who don't have a clue, if you're watching, I had 550, which equated with my breast tissue to a double D. So mine were 550 and that was a double D. So do you have any idea how large her bra size was?
You know, I did not ask. And, you know, normally I do not like to ask because sometimes, you know, the patients are very sensitive, but you can only imagine. So I will say this, these are the largest set of implants, 1200 cc's that I removed today. And I'll tell you in my career, I will never remove more than the 1200 because the maximum they make is 800. And her plastic surgeon was very inexperienced, very foolish, naive, and I will say most likely not even board certified, who put in 400 cc's extra on top of the 800. And if you look, they're more like balls than implants. And the potential, when I was removing and dissecting, I was afraid just the way I was holding, just like some lady would want to get a mammogram, I would potentially rupture that water balloon, if you will. So you can only imagine the care, the sophistication, and as to how. And the sad thing is, when she was on the OR table, she's like, I'm having difficulty breathing because you got these 2 big sandbags sitting on her chest. And God bless her soul, she allowed for me to share her story so that the many other ladies that are out there, even with the 550, 750, I removed 800 cc's last week. And I will tell you, that's a lot of work because right after I did the 800 cc's, the 3rd patient that I did was only 180 cc's. And that was 1/4 of the job, meaning it was a lot of dissection.
So we have
Very happy that she had those removed and say a little prayer for her recovery, for her new first breath. I did find another question here. Leanne was wondering if you repaired the chest muscle during your surgeries.
Yes. So if that's a very good, very thoughtful question. Now, if you look at the pectoralis muscle, it sits on the whole chest and inserts into the upper arm. In the vast majority of the patients, the implant is placed underneath the muscle. Now, when the implant is placed underneath the muscle, be it the average size 350, 450, right? The muscle inevitably window shades up, right? Because look at all those breast cancer patients. When they get their mastectomy, the plastic surgeon comes in, makes a cut in the pectoralis, puts in a tissue expander, and then puts in 90, 110, 150 cc's. And then this patient every month goes to the plastic surgeon. They put in 50, 70, 90, 150, whatever, excuse me, whatever the patient is happy with the tissue expander. Now, 4 months, 5 months, 6 months later, the incision is made, the tissue expander is removed, and the silicone or the saline implant, usually the silicone implant, is then put back in and the muscle is sutured, correct? Now let's go back to vast majority of the patients where there is a cosmetic placement of the implant. So the muscle is cut. When the muscle is cut, what I'm going to do is I'm actually going to do what is this pectoralis muscle? This is the pec major muscle. The pec major muscle, right? The incision usually is made at the bottom, and or even if it's placed through the axilla or placed through the nipple areola, the incision is made at the bottom. No one wants to touch the origin, which is the sternum or the midline, or up in the attachment area where the muscle sits up here. Its incision is made at the bottom part. And so what happens to the muscle when you put in 350, 450 cc implant, the muscle essentially is lifted up. Now the implant is, because you cannot close the muscle. Otherwise, all these breast cancer patients would have had what would be one stage closure, right? You cannot close the muscle onto where it was detached from, usually at the bottom, because you take a needle, you might puncture the implant. Plus, it's like you're putting in a large king size comforter in a small suitcase. You cannot put all of that underneath, right? And so what happens inevitably, the muscle window shades up. It always does. I have all these videos where I show. So this is literally my quote, window of opportunity, literally, to make a cut. And as soon as I make the cut, the implant over time, so now the patient is working out, lifting the laundry basket, lifting the desktop, opening the heavy car door, things like that. The implant now is literally by gravity over time being pushed down because the sternal attached origin is there, the rest, and it gravitates down and laterally usually, as you will see, and the many patients will report. And if you touch the bottom part of the implant, you're going to see the distance between the skin and the capsule is really not much. So as soon as I make cut, literally, lo and behold, without any muscle, the implant's literally hanging down. So this is my window of opportunity in the vast majority of the cases where the implant is down and I don't touch the muscle. The muscle is not there, right? And I essentially right below the muscle. So I'm parallel to the muscle, and an incision that I make right in the crease, an incision that's going to hide. And so I write the capsule and very meticulously, very gently, very sophisticated way, I dissect in that avascular plane, that bloodless field, average blood loss 5 cc's. And I remove the implant capsule and get out of Dodge. What do I do to the muscle? Now remember, over time, the muscle has become atrophied. It truly has not been used, right? Because every time you would use the muscle, you would push the implant against your chest. Now, because I don't touch the muscle, the need for the repair is not there, literally, in the vast majority of the cases. And the muscles, whatever is window shaded up, now settles. That muscle, along with the pec minor, the latissimus, the deltoid, the serratus, now when I have at week 6 the patient's working out, there is no implant. And once the muscle has recovered, they build on this muscle like never before. Because remember, they truly could not work out. This is why the bodybuilder will always get the implants above the muscle so as to not compromise the pectoralis function. Now, another thing I'll mention is the pectoralis muscle, then it sits on the chest and inserts up here in the upper arm. This destabilizes the whole shoulder because now you have a muscle that's anchored. Now, if you have an implant and every time you use it, it hurts the implant because it presses against the rib, what happens? You have unopposed backward movement of the trapezium and whatnot else, essentially destabilizing the anterior shoulder. That in itself is a compromise of upper extremity. So when the ladies start working out, they're like, wow, I've never felt this light, because there's no implant that's being compressed against the rib as a result of the whatever pec it was that was sitting on the chest.
Wow.
Hopefully that answers your question.
I think
Hopefully
it did.
makes
Do you
sense.
guys?
Yes, thank you. I think I answered her question.
Yeah.
Did you see any
Hopefully.
others? You think we covered all the questions?
I
You know,
think
I
we
will
got
tell you-
most of the questions. There was a lot of different
Yeah,
talking and comments,
Yeah.
but I think we got most of the questions. Like scroll through.
I thank you. You have been with us for 2 hours, Dr. Khan. I can't even tell you how much I appreciate it. You're
I
always
have-
so informative when you come on.
No,
I
thank you
just
very
hand
much.
you the ball and you run with it.
Yes. And I will, no, I will tell you, it's a pleasure. It's an honor. You know, this is recorded in history, you know. We'll look back at it on the 25th. Tracy, Becky, and Dawn, we talked about something when the ban happens, like we told you, you know, and it is only right around the corner. I'm going to go ahead and write to the FDA, the director. This is what I was planning on doing over the Christmas break. So at least I have done my part. You know, what is it that we need to do? If each, look, this is a fact, 350,000 complaints to the FDA, correct? Now, I will tell you, there's 350,000 who didn't know how to or where to log on, right? If we just start writing gently, very nicely and humbly and no, BII is real, we are hurting and we improved after, and this is how it's done, they will, i.e. the system, the manufacturers, the plastic surgeons, the doctors will have no choice but to listen. And look, they're listening. I was on hold, as you probably have heard me say this. I was flipping through one of these magazines that are, this is, the you will find at the barber shop, you know, they're talking about BII, the Fortune 500, the Fortune magazine talking about BII, right? This is
That's how I heard about it, was just
Right.
flipping through or a magazine article on Facebook.
Really?
Yeah,
Right.
I had never heard of the words breast implant illness, and I had been so sick.
Oh
And
my
I just
God.
thought this, I had doctors telling me this is your new normal after breast cancer. And I accepted that. I was settling into it, but I felt I didn't know how I was going to continue.
Right.
And I just clicked on that one of those news articles in the,
Right.
it was a magazine article.
Wow.
Yeah. So this is what we need to do. We need to humbly, nicely talk about our experiences, i.e. the patient's experiences, my experiences. I have had patients that come in who had cystic fibrosis, and the plastic surgeon put in basically implants in her. You know, these patients,
Oh my Lord.
that is malpractice. The
Seriously.
surgeon's license should be revoked, if you ask me. There's
Yeah.
my neighbor who had a kidney transplant, and she was on immunosuppressive medication. She got breast cancer, and she ended up getting implants. Horribly wrong mental process, unjustifiable, inexcusable. This is called, how irresponsible can someone get, an MD? Now I'm going to say, still practicing. Anything that moves, he'll put an implant in. Why not? The bottom line, and I say this very professionally, and I say this to you, how can you justify it? Yes, she has a right, but you have to think for her. Because sometimes I do not know what's right or wrong for me. I want someone to think positively and wisely for me, so that I don't look back and say, you know what, I made a big mistake. This is where the patients need to write. They need to, look, I have a nice nurse from New Jersey. She's been a surgical oncology nurse for the last 40 years. She went to her endocrinologist, her cardiologist, and she's giving him articles, and literally, and now these docs are receptive because they know she's a nurse. She's works in the medical field, and she is basically an educated, learned person who's involved in research, and is another, quote, source of information, because these doctors are genuine. They want to learn. And remember, medicine 10 years ago is very different than what it is now. 10 years from now, it's going to be very different, and we always need to keep changing with the times. Sad thing is, we're repeating history. We're reinventing the wheel. Implants were banned in 92. Now we're going to ban them again. And it took this long, this much effort for what is so obvious. Sometimes I will say this, I laugh and I say, wow, the evidence is so mounting. It's like smoking kills, vaping kills, right? Juul cigarettes kill, implants kill. and I use the word kill. I remember that one point that you mentioned before the FDA. You were one of the women who testified before the FDA and said, how many women committed suicide because of the suicidal ideation? We do not know. That's a real number.
Mhm.
I see these patients. I tell the FDA, please come and spend time with me in clinic. A half a day, one day, we'll get permission from the patients just so that they can listen in and hear the patients themselves, because these are real people with real lives
Mm.
and real families and real productivity that they can certainly offer. And it's not only them, but their significant others, their kids, their neighbors who are all hurting, and it's not only them. And it's not fair that it continues to be marketed as safe. And that is, if I get on a plane right now with the three of you and we go to the top 100 hospitals in the country, all 100 would say implants are safe, standard of care, put them in because you only deserve better. That is still in 2022 being practiced and preached despite the FDA warning, and as if nothing happened. And this is what needs to change.
Amen.
Yeah.
We're gonna do it. We're gonna make some changes little by little, and otherwise it won't get done. So each little change, it's gonna snowball, and we're gonna change other states, and we'll go for it all federally eventually, damn it. Because it's worth it.
I'm with you.
It is.
And,
And we're lucky to have doctors like you, Dr. Khan, with us.
yes, no, I will
Yes.
tell you, I will say this, we have a lot of good docs out there. We have a lot of good, faithful people with good leadership roles in the FDA. They're listening, albeit slowly. We have the evidence that's only speaking in our favor. There is clear evidence that's speaking in our favor. It's only a matter of the time before all of this will basically translate into what is going to be a permanent ban, not only for silicone, but saline implants. We just need to be assertive, positive. We need to be very humble in our communications, and one day at a time. Look where we are. 1 year ago, 2 years ago, 5 years ago, and where we're going to be hopefully very soon.
I hope
You know,
you're right.
I admire your platform, Tracy, Becky, and Dawn. This was very nice, very effective. Let's do another round whenever you're ready. Bring me on, and we'll certainly go ahead and discuss as we get more evidence, more papers. Continue to write every day. There is, believe it or not, I have a phone call that I have to make to Italy, to Rome. That's where the patient is. She is seeking consultation for explant surgery because she knows that she heard either one of my old patients or my last Facebook Live or another patient talk about her experience. This is what you call changing lives, not only in the US, but internationally, everywhere, because at the end of the day, we're all human. We all will feel a needle poke, and we all will react negatively to the implants.
I agree. Well, thank you, Dr. Khan, and thank you, Becky and Dawn Ann.
Thank you, Tracy, for having us all on here.
Hopefully
Thank you.
we've enlightened some people.
This was great. Thank you so much.
And you know what? I have another book. I don't have it right here, but Tara Hopko, who's in New Jersey. I met her at the FDA hearings. I have several of her books. Let me get this off my chest. And it's a quick little read about her journey with breast implant illness. So whoever wants a copy of the book, comment book, and then you got to share this video, and then I'll put you in a drawing just like I did last week.
Wonderful.
And I'll give away a free book to whoever wants to comment book and then share this video.
Great.
Thanks everybody for tuning in.
Yes,
Thank you.
thanks
Thank you.
everyone. Thanks for your time, Dr. Khan.
Thanks,
Anytime.
Dr.
Pleasure,
Khan.
pleasure to be on. Stay safe, keep warm, and until next time, all the best. God bless you all. Thank you.
Yes.
Thanks,
Thanks.
everyone.
Bye, Tech.
Bye-bye.
Bye.
Bye. Thank you.